I hope you are able to upload. Not able to
Yeah.
upload? Yeah, okay.
Do you want me to?
Yeah, upload.
Okay.
Yeah. That's why I stopped. Yeah. And make a single window. Yeah. Right.
Okay. Shall I start?
Make it slideshow and start. Yeah, good.
Okay. Good evening, everybody. Thank you for joining again. Last time on Friday, I started with A and we came up to H, and today we'll continue with I. So today we'll talk about implantation defects. Although it's been 40 long years since the first IVF and more, after we put the embryos back is where we lose control over the cycle, and that's where everything has to happen naturally. So it's like planting a seed, but the plant has to grow on its own. So this is where we have tried a lot of different ways to improve the implantation. There has been a thought of using IVIG, intralipids, corticosteroids, thinking of mother and child as graft rejection. So they've tried to do that. They have tried to use embryo glue to actually stick the embryos to the endometrium. They've tried assisted hatching to improve the embryos implanting. The endometrial scratch and ERA have been tested to see that we can match the endometrium with the embryo when we transfer. Elective freeze-alls have been tried, and as far as the sperm is concerned, IMSI and PIXI have been tried. The time-lapse and PGTA for all have been tried, but the HFEA, or the Human Fertilization and Embryology Association, says that all of these have only limited evidence, and they are mostly small studies that cannot be applied to everybody. So they have come up with a traffic light system with all of these add-ons, and all of what I have enlisted here fall under the red or the amber list, which means they should not be used routinely in all patients. So we are still lacking on evidence when it comes to implantation defects. Next, juvenile conditions. So as early as in the childhood, there can be impact on their future fertility. So whenever there are childhood cancers, there can be impact on the fertility because the cytotoxic drugs can be gonadotoxic. So whenever we deal with childhood cancers, remember to think about the future, because yes, we have come to a stage where we are able to give them very good survival rates with cancer treatment. So when these children go on to become adults, of course, fertility is also something we need to think about. So as far as male child is concerned, think about sperm cryopreservation, and for prepubescent girls, we would think about ovarian tissue cryopreservation rather than oocyte cryopreservation. Although ovarian tissue cryopreservation is still at the stage of trial, but that is an option we can think about. And with ovarian tissue, we actually place back the ovarian tissue into the body. That's one of the things, or the other one is to do it in vitro maturation. The other condition is mumps, which can affect both boys and girls. So it can lead to orchitis and oophorytis and bring about a decrease in spermatogenesis and oogenesis, respectively. But with widespread vaccination, this is something that has been tackled. And of course, if in those individuals who have had mumps and which has resulted in gonadal failure, we will then have to think about using donor eggs and sperm or maybe surgically retrieved sperm and do an ICSI. The other condition which can start in childhood itself is hypogonadotropic hypogonadism, which could be due to hypothalamic or pituitary causes. Some of the conditions which can lead to this are Kallmann syndrome, which can impact both boys and girls. There could be panhypopituitarism, also affecting the gonadotropins, and there could be conditions like craniopharyngioma or tumors in the pituitary, which can lead to hypogonadism. So this is classically the WHO class 1 anovulation, and in your hormonal profile, you will see low FSH, LH, as well as estrogen. If the cause is predominantly due to hypothalamic causes like stress, or when there is very extremes of BMI, high or low BMI, eating disorders, or conditions like Kallman syndrome, think about using pulsatile GnRH, because the deficiency is of GnRH, and providing pulsatile GnRH actually brings about release of natural FSH and LH from the pituitary. But this is quite cumbersome and is expensive. So the alternative is to directly provide FSH and LH, and these gonads are usually very sensitive to the external FSH and LH. If it is pituitary causes like prolactinomas and pituitary tumors and also craniopharyngioma, you would think about giving FSH and LH. And again, the gonads are very sensitive to FSH and LH. These individuals would also require HCG to a certain extent as luteal phase support, and they do very well in any fertility treatment because there is no defect with the ovaries or the testes as such. Person is George Washington, and any guesses what this condition was? So he had Klinefelter syndrome, and this is one of the chromosomal abnormalities in men which can impact the fertility. Okay, so I did talk about C for chromosomal, and one is Klinefelter syndrome in men. So they present with testicular failure, and testicular failure would mean that the production of sperm, so spermatogenesis, is affected. So the options are, we can try to do a surgical sperm retrieval. And whenever I said earlier, if we do a surgical sperm retrieval, the option always is to do an ICSI with them. But if there is no sperm retrieved or very few sperms that cannot be used in ICSI, then you will have to think about donor sperm. This is, however, not a condition that is inherited, which means that the children born to parents of Klinefelters will not directly inherit this condition. This is predominantly related to advanced maternal as well as paternal age, just as with Downs, which is associated with maternal age. This is a condition which can be seen when both of the parents are older. Then coming to lesbian couples, so in this equation, there is no man, so it's a female with female. That means we have to use a sperm donor. So the option is to do an IUI with the sperm donor or to do an IVF. And the unique situation of shared motherhood, reciprocal donation, or intra-partner egg donation can also be tried. So this is a situation where both partners can be involved in the pregnancy, and that's the egg of one of the partners is that the embryo is transferred to the other partner. This way, both of them can participate in the pregnancy of their children. Next is mitochondrial disorders. So mitochondrial disorders, you might know some of the rare conditions like Leber's hereditary optic neuropathy, Leigh disease, Alpers syndrome, all of these which have neurological defects and lead to developmental disorders in the children. And these are incriminated to the maternal mitochondria. And you may all remember right from anatomy days and physiology days, the mitochondria are the powerhouses, and they are found in the cytoplasm outside of the nucleus, and they also contain some genetic material, and this is what is responsible for the inheritance of these rare disorders. They are rare, but they are quite serious and can have serious impacts. So the new technique of bringing about a 3-parent IVF, or involving 2 eggs, that is one of the mother and one of a donor, and the sperm from the father. And this is a unique situation where there are 3 parents involved in IVF, and I'll talk about both of them. One of the methods is to do a pronuclear transfer. The other is to do a maternal spindle transfer. So essentially, less than 1% of DNA from a donor is used in this, and it's only the mitochondrial DNA which contributes to less than 1% of the DNA is what is used in this sort of IVF. So explaining both of them, the first technique is called maternal spindle transfer. So what is done is, if you can see here, this is the patient's egg and this is the faulty mitochondria. So the nucleus from the patient's egg is removed, and the nucleus from the donor egg is removed as well. And then the patient's ovum is replaced with the nucleus from the donor egg. And now if you can see, it's the mitochondria, which is abnormal, has been replaced by the normal mitochondria from the donor. And then this egg, which is a hybrid from the patient and the donor, is then inseminated or injected with the partner's sperm. So in this way, we have gotten rid of the faulty mitochondria from the mother. The other option is pronuclear transfer. This is when the patient's egg is first inseminated or injected with the sperm, and then once the pronucleus is formed, that pronucleus is transferred into a donor's egg by removing the nuclear material from the donor. And then finally, the zygote does not contain the faulty mitochondria from the mother. So in this way, although mitochondria contributes to less than 1% of DNA, that is also eliminated from the equation so as to avoid the serious conditions like long labors and so on. Next problem is of no uterus. So no uterus could be congenital, like the MRCOG syndrome, or it could be post-hysterectomy, or there may be a uterus, but the endometrium may not be conducive for a pregnancy, like with complete abdomen, which is due to repeated DNCs, or complete netters, which is due to infectious destruction or endometritis, like tuberculosis of the endometrium, or due to schistosomiasis in places where it's epidemic. So in such situations, the options are surrogacy, because the fault is with the uterus. And of course, if you're in the right place at the right time, uterine transplant could also be an option. Next problem is ovarian insufficiency. We did deal with this with fragile X syndrome, but there are other causes as well that can impact the ovaries. So the diagnosis is when the FSH is more than 40 at age less than 40. So more than 40 is usually what is expected in menopausal age group, but at less than 40 years, if it's more than 40, then this has to be repeated twice, 6 weeks apart, and that makes a diagnosis of premature ovarian insufficiency. If this is a condition in women less than 30 years of age, then a karyotype is also essential, because probably we are dealing with a mosaic Turner's who has presented quite later on, because usually Turner's presents with primary amenorrhea, but if they come with primary infertility, we'll still have to think about doing a karyotype to rule out mosaicism. Autoimmune screen, because adrenal autoimmune conditions are most commonly associated with ovarian insufficiency, and also antithyroid antibodies may be present in such individuals. And 50% of the times, there are no causes for ovarian insufficiency. In such cases, again, management could be to do with a self-IVF, again, bearing in mind that the success rate could be quite low. Mosaic individuals do have natural fertility of about 8%, but in many of them, we may have to offer donor egg due to low success rates with self-egg. Next and favorite condition, polycystic ovaries, P for PCO. So the diagnostic criteria for PCO was in 2004 in Rotterdam, and it said oligo or anovulation, which is WHO type 2 of anovulation, hyperandrogenism, either clinical, that is in the form of acne, hirsutism, or free testosterone index or a lowered sex hormone binding globulin, and polycystic appearance on transvaginal ultrasound. Earlier, it was more than 12 follicles, but now it is more than 20 follicles and a volume of more than 10 cc. So any 2 out of these 3 makes a diagnosis of PCO. Then in Amsterdam in 2012, they added to this the long-term health effects of polycystic ovaries, and they are the metabolic side of things, which is the insulin resistance leading to them being prone to develop type 2 diabetes in life, and also the high BMI can contribute to diabetes and on the whole metabolic syndrome in polycystic ovaries. They can also have obstructive sleep apnea, cardiovascular diseases later on in life, and also prone to cancer like endometrial cancer due to endometrial hyperplasia. And the management was in the Thessaloniki 2008, and they said lifestyle is the first line of treatment, and that is even a 5 to 10% weight loss will improve the ovulatory pattern as well as response to treatment, and also have a better pregnancy outcome in such individuals. The Cochrane review said metformin definitely adds a benefit to the treatment in PCO from the metabolic standpoint. Ishray says both clomiphene and letrozole are first-line medical management of ovulation induction in polycystic ovaries. So if you know, what is the main problem with polycystic ovaries? First, the follicles don't grow. And since the follicles don't grow due to hormonal imbalance, there is no ovulation. When there's no ovulation, the periods don't come regularly on time. Again, from fertility standpoint, if there's no ovulation, there's no pregnancy. So ovulation is handled by clomiphene citrate and letrozole. If there's no response to that, then gonadotropins is next. But you have to know that these individuals are at high risk of developing ovarian hyperstimulation syndrome because there are so many follicles in the ovaries, as we said, more than 20. So they are at risk of OHSs, and we have to be careful while starting gonadotropins from them. Again, in IVF, this is a risk factor that we have to bear in mind when it comes to women with polycystic ovaries. And of course, long-term follow-up, because I said they have long-term health effects as well. And pregnancy also has to be followed up because they are at risk of developing GDM and high BMI related complications. Next, Q for quadriplegia in men. So mainly the fertility is impacted, and this is usually seen in men with spinal cord injuries. So the issues are erectile and ejaculatory dysfunction. So from the sexual health point of view, medications to bring about erection as well as ejaculation can be tried. Mechanical methods like vacuum devices to bring about erection, as well as certain vibratory devices can be used for ejaculation. And if neither of them are possible, then next is to do a surgical sperm retrieval. The production of sperm, however, is not impacted in quadriplegia. So if medications and mechanical methods are able to bring about ejaculation and erection, then even an IUI can be attempted with the ejaculate. But if not, then surgically retrieved sperms will have to be used in an ICSI. As far as women are concerned, usually quadriplegia doesn't impact female fertility, although it may result in sexual dysfunction and orgasmia, but that doesn't have a role to play in terms of fertility. But pregnancy can be a high-risk pregnancy with quadriplegia, putting them at risk of VTE and other complications. Recurrent miscarriage, this has always been a problem, and there have been extensive studies that have been done in recurrent miscarriage also, because as I told in my previous talk, it's not just about getting people pregnant, but it is also to ensure that they stay pregnant. The Green Top guideline has a definition of more than 3 consecutive losses, and ISHRAE says more than 2 consecutive losses for recurrent miscarriages. So what are the do's and don'ts? When it is repeated miscarriage of more than or equal to 3 in the first trimester, then the investigations to be carried out are APLA. So APLA includes the blood test for lupus anticoagulants as well as anticardiolipin antibodies, and they need to be done twice, 12 weeks apart to call it positive for APLA. Pelvic ultrasound to look for abnormalities in the uterus, which could be causes for the first trimester loss, or if there are consecutive 3 losses, the third product of conceptus has to be sent for karyotyping, and only if there are abnormalities like unbalanced translocations that are found in those products of conceptus, then parental karyotyping has to be done. But when the loss is in the second trimester, that is taken more seriously, because we know that once the fetal heart rate comes into play, then the chance of miscarriage falls to less than 1%. But if it has happened after second trimester, then that is taken seriously. So even with 1 loss in the second trimester, APLA and other thrombophilias like factor 5 and 2, protein S and C should be done. Pelvic ultrasound, again, to look for uterine anomalies, and uterine anomalies could be indirect indications that there could be cervical weakness as well, because most of the time cervical weakness is associated with uterine anomalies. Products of conceptus again need to be sent for karyotype, and if abnormal, parental karyotype needs to be done. So the management of each of the problems, if it is APLA, then low molecular weight heparin and low dose aspirin need to be started. And according to ISHRAE, even in the preconceptional period, low dose aspirin needs to be started. And this reduces 54% of the miscarriages brought about by APLA, so it improves the live birth rate. Cervical cerclage can be looked into for those who have a classical history of mid-trimester losses due to cervical weakness. And in those with karyotypic abnormalities in the products of conceptus and in the parental chromosome, then genetic counseling and implications for the next pregnancy, and IVF with pre-implantation genetic diagnosis can be attempted. The don'ts when it comes to recurrent pregnancy losses are TORCH no longer is advised. Routine screening for bacterial vaginosis is not to be done. 3D ultrasound has no added benefit if just pelvic ultrasound is able to make the diagnosis. So routine 3D is not required, but if the pelvic ultrasound that is done as a preliminary test shows abnormalities, then a 3D does add to the benefits of diagnosis. Routine HLA typing, maternal antibody testing, uterine or peripheral NK cells do not give us enough information when it comes to recurrent miscarriages. Again, treatment options like corticosteroids, IVIG, which again, I said during implantation defects as well, doesn't have any benefits. Low molecular weight heparin and low dose aspirin for first trimester losses with thrombophilia and unexplained infertility has no role, but they do have a role in second trimester losses due to thrombophilia. Progesterone, HCG, LH suppression, metformin, all of these have questionable role in unexplained infertility. They may have some role in polycystic ovaries, again, not to be routinely tried. PGS for all, again, is not recommended, both from the standpoint of recurrent pregnancy losses and recurrent implantation losses, implantation failures. Immunotreatment, like replacement of paternal leukocyte transfusion, all of that is not to be attempted. And septal resection and metroplasty, again, metroplasty does more bad than good because it puts the woman at risk of uterine rupture in the subsequent pregnancies. Septal resection in selected cases may have a role when it is recurrent first trimester losses. So next, coming to S, which is sexual dysfunction. So the causes in women could be vaginismus, vulvodynia, dyspareunia, or low desire. The investigations to be done are, as far as vaginismus and vulvodynia are concerned, these are usually diagnoses of exclusion. They have multiple pathologies that contribute to it, but the main reason is still not known. So examination is to be offered gently to look for pressure points and trigger points in cases of vaginismus and vulvodynia. Vaginal swabs need to be taken to rule out infections because they could be the reason for vaginitis causing pain. Prolactin levels to be checked because that can lead to low desire and low libido. And again, prolactin not only affects the sexual drive, but also leads to hypogonadotropic hypogonadism and is one of the causes of WHO type 1 of an ovulation. So testing for prolactin in women has a role, especially when they're symptomatic like headache, visual field defects, or they come up with galactoria. Another thing to remember is the lady might be still breastfeeding. So when a lady comes with secondary infertility and is trying for the next baby and has irregular cycles, just one question of, are you still breastfeeding, will probably give you the answers, and you don't have to do elaborate testing in such women. And of course, if nothing has helped, psychosexual counseling and treating it with a multidisciplinary approach might be the best way to go ahead. So pain management is essential with those with chronic pelvic pain. Psychotherapy can be tried, especially if there is history suggestive of sexual assault or abuse, which is leading to sexual dysfunction. And in situations, again, like hyperprolactinemia, think about dopamine agonist. It could be that there is a reduced lubrication, especially in the postpartum dyspareunia. So lubricants may help, and local estrogen creams might help. And if the woman is not able to bear sexual intercourse, then IUI might be the option for a fertility treatment. In cases of transgender individuals, once they had gender affirmation management, ideally, it is best to have a fertility preservation before the cross-sex therapy, because when a trans man is treated with testosterone and when a trans woman is treated with estrogen, the production of the gametes is significantly reduced because of the cross hormones. So it is better to offer fertility preservation before. But if this has not been the case, then temporarily the cross-sex hormones need to be stopped in order to improve the retrieval of the gametes. And this has to be done before any gender confirmation surgeries. So for trans men, the options are, so these are individuals where a woman born biologically as a woman wants to have confirmation into a man. So trans men, the options are to do oocyte cryopreservation, ovarian tissue cryopreservation if they are young, people, and sometimes trans men who have uterus may decide to carry the pregnancy themselves. So that is the reason why the term people with pregnancy has been introduced, and not just women with pregnancy or mother. The term people with pregnancy is used in such individuals. Again, the other options are for their partner or surrogate to carry the pregnancy if they come to us after they've had their gender confirmation surgeries. Trans women, the options are sperm cryopreservation. So these are individuals who were born as men but have transformed to women. And the option of carrying the pregnancy could be either by their partners if they are in a homosexual relationship, or by surrogate if they are in heterosexual relationships. I still have quite a few slides to go, and I think I'm left with 2 more minutes. So I think this is the last condition I'm going to talk about, which is unexplained infertility. So the definition of unexplained infertility in women less than 40 years of age, the first year of trial into fertility has a fecundity rate of 15%. In the second year, it drops to 5%. So what this means is the cumulative pregnancy rate at the end of first year is 80%. So 80% of couples where the woman is less than 40 years will fall pregnant in the first year of trial itself. In the second year, the remaining 10 or total of 90% will have pregnancy. So that leaves us with 10% who have subfertility at the end of 2 years. And after multiple studies into treatments like the FAST trial, which compared IUI versus IVF, and many other trials like that, the meta-analysis said IVF is the treatment of choice after 2 years of trial in an unexplained infertility. And that is what the NICE guideline has adopted, and said that after 2 years, if they have tried and if there are no other causes found from both the male and the female partner, the best treatment is to do an IVF. And because IVF is not only the treatment, but it may give us some of the answers about why they've not got pregnant, like oocyte quality abnormalities, which we don't know without testing, because our tests are only indirect measures like hormones and ultrasound. But by actually looking at the oocytes under the microscope, we may be able to find something. Again, there might be sperm functional abnormalities, like sperm may be moving okay, maybe of good numbers, but they may not be able to fertilize the eggs. So IVF not only gives us the treatment, but also gives us the answers to the questions when it comes to unexplained infertility. And finally, there could be problems in the embryo itself. The embryos may not cleave properly, they may fragment, they may not expand. And these are some of the unexplained reasons why there could be infertility. Adding to that list is DNA fragmentation index in the sperm, which again is questionable according to HFEA and is still not on the traffic light system. So I'm left with last few letters, and I think I'll come back to it on another day with you all. Thank you very much for your patient listening, and